Scabies, a parasitic skin infestation caused by the Sarcoptes scabiei mite, primarily transmitted through direct and prolonged contact with an affected individual. Manifests with erythematous pruritic papules, scattered vesicles, and thin curvilinear burrow tracts, especially on the wrists and interdigital folds. Etiology: pathogen, Sarcoptes scabiei var hominis. Transmission: highly contagious, typically via direct prolonged physical, skin-to-skin or sexual contact. Rarely indirect transmission, e.g., sharing textiles such as bedding, towels, or clothes. Commonly affects children and individuals living closely with other people, e.g., in nursing homes or jails. Risk factors: crowded living conditions, e.g., institutions such as nursing homes, hostels, child care facilities, and prisons. Scabies mites cannot survive more than 2 to 3 days away from human skin. Clinical features: incubation period, approximately 3 to 6 weeks following infestation. Intense pruritus that increases at night. Burning sensation, skin lesions. Elongated erythematous papules, burrows of 2 to 10 mm in length. Scattered vesicles filled with clear or cloudy fluid. Excoriations, pustules, and secondary infection. Predilection sites: wrists, flexor surface. Medial aspect of fingers, interdigital folds, hands and feet. Male genitalia, e.g., scrotum, penis. All other intertriginous areas of the skin, anterior axillary fold, buttocks. Diagnosis: diagnosis is typically clinical. Detection of mites, larvae, ova, or mite feces on any of the following. Dermoscopy: microscopic examination of the skin. Skin scraping and histology, low sensitivity. Scabies may be mistaken for eczema, especially as the topical use of glucocorticoids initially alleviates symptoms. Treatment: general principles. Start treatment with a scabicidal agent. Treat pruritus with oral antihistamines and/or topical corticosteroids as needed. Treat secondary bacterial infection of the lesions with topical or systemic antibiotics. Advise all patients on measures to prevent transmission and reinfection, to trim fingernails to reduce the risk of excoriation and superinfection, to stay home from school or work until treatment is completed. Itching may persist for up to 2 weeks after treatment. If symptoms last longer, consider treatment failure, reinfection, or alternative diagnoses. Scabicidal agents. First line for adults and children. Permethrin, 5% cream dose may be repeated in 1 week, for adults only. Oral ivermectin crotamidone, 10% cream lindane, 1% lotion. For adults and children, sulfur, 5 to 10% ointment. Oral ivermectin has limited ovicidal action. If used to treat scabies, a second dose is required after 14 days. Mechanism of action of lindane: blocks GABA channels, neurotoxicity in the mite. Prevention of transmission and reinfection. Wash all clothing and bedding in hot water, 250 degam, 122 degam. Treat all of the following individuals simultaneously with the patient: household members within the last month, sexual partners within the last 2 months. Advise household members to avoid direct, prolonged contact with the patient's skin, bedding, and clothing until treatment completion. In the event of a suspected outbreak, notify the local health department. Increase surveillance to identify new cases.